Okay, good afternoon, everyone. Good afternoon. It's great to see so many familiar faces and some new ones as well. My name is Maura Little. I am the executive director here at Cambia Grove. Cambia Grove is a catalyst for healthcare transformation. We focus on helping innovation thrive in our domestic healthcare system, and we could not be happier to welcome Dr. Mokdad here to discuss health outcomes, cost and quality between our domestic healthcare system and the rest of the world. It has been some fascinating conversations already, and we are looking forward to continuing the conversation with all of you here tonight. As you might know, if you've been to Cambia Grove before, we do gatherings like this pretty much every month or so. Feel free to sign up for our newsletter. Feel free to use this space. We are open 9 to 5, Monday through Friday, to host other conversations around transforming healthcare in the U.S., and also have a number of different international delegations come through here as well. So please engage with us, and thank you all so much for joining us tonight. With that, I will turn it over to our host, Lee Huntsman, and please join me in welcoming both Lee and Dr. Mokdad.
Thank you, Maura. Good afternoon, everyone. Ali, let me add my word of thanks for coming and joining us today. Maybe to start, tell us a little bit about who you are. What's your professional trajectory been, and what's this job you have?
Good job. I love my job. So I'm an epidemiologist by training and a survey methodologist. And I've worked at CDC for 20 years, and I was lucky to be recruited to UW at the beginning of the Institute for Health Metric and Evaluation, where I'm a professor. And we provide health data for every country in the world and location. So, and I'm pleased to be part. And I want to give a shout out for our staff. You know, you guys know IHME and you think it's faculty. You hear Chris Murray and other faculty. We have wonderful staff who make us look good and who do our job. So thank you for my staff.
Hey, all right.
IHME staff.
Well, we'll look forward to interacting with your staff as well as you afterwards when we have the refreshment time. But speaking of staff, IHME is not very well known in this town, although it's very well known worldwide. It's just a little closet operation over here on Fifth Avenue, right? How many staff do you have?
So IHME is started in 2007 by 3 people. We're currently about 560, and we have about 35 faculty. And we have a wide variety of expertise, from demographer, programmers, IT people. We're working a lot on visualization, and disciplines from economists to statisticians, demographers. And we are right now have memorandum of understanding with the World Health Organization that the WHO will use our numbers.
Wow.
So in a very short time, and I'm bragging on behalf again of the staff, in a very short time, this little institution that was funded here at the University of Washington got a lot of support from the university, of course, and from the community. But in a short time, we positioned ourselves as the leaders in data and health sciences and health metrics.
You certainly have, but it's one thing to say that. It's another thing to kind of get our mind around the scope of what IHME does. So the geographical reach in terms of countries, the depth of the data, the frequency of the data. Tell us what the data product, well, what it has been and what it is now.
So IHME was funded originally to do several things, including one of the main products that we do is the global burden of disease. And the global burden of disease is an effort in a systematic and scientific way to document health loss, injuries, and risk factors for every country in the world. And IHME right now provide a burden of disease for 195 countries. Soon coming up, it will be more than 200. And for many countries right now, we have either grants from the Bill and Melinda Gates Foundation or from the country itself, where we are doing subnational. So in the US, we do at the state level, soon at the county level, Brazil at the state level and county level, China at the county level, India at the state level, Pakistan, Kenya, Japan, England. So right now we're about 600 locations that we provide data for. To give you, you're very correctly about the scope of what we do. Every run from IHME, a global burden of disease, is billion and billion of numbers. I mean, it's that much capacity because we do it by country, by year, from 1990 till now. We do it by age, by sex for each country. And we do it by 350 diseases, 87 risk factors, 2,500 sequelae of these diseases. So like diabetes imputation, diabetes blindness. If you count all of them by location, by sex, by age, by time, that's a lot of data points. And then what we do, which makes us a little bit unique than everybody else in this business, is we have a generalist grant as a core funding for something called public good. So our data has to be public. And we put it on our web for everybody to get access to it. Not only we release the data, the outcome, we don't release raw data when we get raw data from a country. We release the computed data. We also release the programs that produce these numbers. So in the first time in history, such an effort, not only by us here, the 560, we have 4,300 collaborators from all over the world working with us. It's not us only. We have collaborators in 145 countries. And then I cannot be here sitting in Seattle in an office claiming to know what's happening in Nigeria without having people from Nigeria working with me and giving me feedback. And this large network of collaborators make us even do a better job every time. The core funding from the Gates Foundation is for annual update of the global burden of disease, so we do it on an annual basis now. And we produce other, briefly, can I say what else we produce? Sure. We produce something called health access and quality of care. For every geographic location we work in, we rank countries on their health access and quality of care. We monitor all the sustainable development goals that are health related, and we produce a report on that yearly. We have a health, we have one of our economists here, but we do health financing where we see every country where the money comes from, government of the United States, who gets it in that country and where it's spent on. And we track that money, and we do also, right now we have something called future health scenarios where we take our burden in 2017 and soon 2019 and project it to 2040. We take spending in 2019, project it to 2050. And the idea here is to provide policymakers with what-if scenarios. Not only to tell you your burden today, but your burden in 2040. And the idea here is not to come to a country like Saudi Arabia or Nigeria, if we're talking about Nigeria, and say where diabetes would be in 2040, is to provide the policymakers in Nigeria what happens if Nigeria reduces smoking, reduces obesity by a certain percentage? What will happen to diabetes and the burden of disease? And the idea here is to empower people to make the right decision on what's very important for their geographic location in order to make a change. We have an arm at IHME that does policy that people don't hear about a lot. We produce policy report working with countries, so what does it mean? And it's very important for us at IHME, and we can talk about this later on, is not only to provide a number. You know, you and I know very well putting the best numbers out there is very good. That's the beginning, that to show where you are. If you don't know what your problem is, you cannot fix it. And then we keep repeating doing this so you could see evaluation of what you intervened on. Did it make a difference, yes or not? But the most important is the so what. You told me diabetes is my biggest problem here. What should I do about it? and IHME is getting into that too.
So this is not just a data science project, it's a triumph of collaboration. Thousands of collaborators producing these data at an extraordinary granularity
Yes.
and regularity. I remember when the IHME reports were, 3 volumes of Lancet or whatever they were every 3 years, and now it's annual or more often, or?
It's annual right now. The only time we produced 2017 and we were supposed to 2018, but because we signed this memorandum of understanding with WHO, we delayed 6 months the release of the GBD 2000. So now it's 2019 to coincide in May with the World Health Assembly.
Okay.
So that's part of the MOU. And part of the MOU with WHO is we work with countries to make sure these numbers are used and understood, and we provide training. IHME, the first GBD that was produced by IHME, you're right, it used to be a large volume, was in 2012, and it was the Global Burden of Disease 2010. And for the first time in Lancet, it was the whole issue devoted for one topic.
Mm-hmm.
And this has continued with Lancet. We have a good relationship with Lancet. They give us a hard time like any other paper. They reject more paper if anybody knows Lancet. They reject a lot of our papers too, and sometimes they shouldn't. So this beautiful relationship is, scientific, not publishing for IHME. And we have had a wonderful platform for us to release our global results. We have a similarly with New England Journal of Medicine and JAMA, where we publish other papers of different topics. And we, on purpose, try to, depending what message we want to send, decide what journal is the best for it. So if we're publishing about the United States burden of disease, which we are doing, we prefer to publish it in JAMA, because that's the Journal of American Medical Association. So we came a long way, hard work, a lot of work, a lot of smart people, and we are, by Reuters, we are classified as the largest collaboration in health. Not me saying it, but we are one of the largest collaboration in health. The problem with collaboration is twofold. One of it is you have smart people telling you what to do, you end up doing a lot of work. And then if you see what we deal with this big collaboration is, I send a draft paper for our collaborators for any topic, say diabetes, you get thousands of comments. And we have a mechanism at IHME, and that's what makes us a little bit different, where our staff have systematically created a way for the feedback. It comes to us, say the first author on that manuscript is Ali Mokdad. There'll be things flagged for Ali to fix. And there'll be things that are very important that will be flagged to our director about the GBD. So the different triage where these comments have to be within IHME to be resolved. And then we have a council for GBD, and we have an independent advisory group for led by Peter Piot, funded by the Gates Foundation, has people from WHO. So we have people keeping an eye on us to telling us what to do, and these smart people make you do more work. And if you meet our director and you have a good idea, remember, if you tell him, he'll go and do it, but it means the 560 staff have to work harder to do it. So good ideas are welcome, but they come at a hard expense. The other thing that IHME, the collaboration, which is very important to say, we at IHME spend a lot of time through our faculty and our collaborators to think about a topic in order to do it right. We have, everything we put out, we have a rigorous mechanism to check on the quality and the output. Yeah, we're humans, we make mistakes, billion of numbers, there'll be some numbers that are wrong, that's acceptable and expected. And as much as we can, we try to make sure we have the best science out there. But what's good about IHME that is unique in this collaboration, if you come to me or to Chris or to Theo or any of our senior faculty or any of our junior faculty, and we have a junior faculty here, and you come to me and say, hey, Ali, this is wrong, you should do it differently. My immediate reaction, I may not tell you, Lee, to your face, but in my head goes in, we spend a lot of time, buddy, on this one. We thought about it very hard. But one thing about IHME, we change in a heartbeat when we get a recommendation to do something better. And to give you a reason why this success story is, when we do a GBD, we have a cut point that we say no new studies updated will come here after this date. So we stop reviewing literature, we feed it into our machinery, let's go into production. We have a director called Christopher Murray. If you don't know him, he comes sometimes to a meeting and say, that was 2 weeks old. I want you to go and review all the literature in the past 2 weeks and then rerun it again. It's that much of tension and attention goes into detail. And then if you look at the history of Christopher Murray and IHME, people who have criticized him openly about something that he shouldn't done or should do differently, he goes and changes it in a heartbeat. And he surrounded himself with a lot of people who think exactly like him. And then we are listening to any feedback. We have a mechanism to get these feedback. But if we have a product that we can do better for providing service in a country, it will be changed like this at a very high expense from IHME, but we change it because none of us at IHME has a, how to say it, has a beef in a topic. So let's put it, I mean, before us, people in malaria will go to somebody for funding. I'll say malaria is killing so many people on diarrhea. We don't. At IHME, we don't have a stake in a risk factor. We don't have a stake in a disease. For us, we have to do it systematically in a way, and then we want to produce the best product. And our value added is by being rigorous in science.
Well, I really want to talk more about the nature of the data, how it's changing, and what the implications are. But first, tell us a little bit about the quality of the data. I would have thought that there would be sociological and political factors that perhaps attempt to influence the data, because the data can reflect well or poorly on a nation or operation or whomever, and there might be motivations to be more or less rigorous with the data. But clearly you have, I mean, IHME has been doing this for a while now, so this network must be pretty robust. How did that come to be?
So the network is pretty robust, and you have, as you said, you have a diverse group, which we invest in having a diverse collaborator group from everywhere with different background and different topics. And you would like the experts on mental health, the expert on diarrhea, the expert on vitamin A to be involved in what you do. And yes, they fight among themselves whose number is higher. But we have put in place a system for how we do things and how we fit it in a model and how it's scientifically the way it's run. So there is no way for us to treat vitamin A different than malaria in our model. So that's one way. Two, and here there is a big thank you to the support that we have from the Bill and Melinda Gates Foundation that creates that independence for us. So we are not dependent on a donor by a disease or by a risk factor. We have what we call a core funding for a public good. So that gives us some cushion to do that, and we're not being influenced by all these factors. The last thing that is really what you're saying, and I want to be straightforward and say it here, we are not an agency that countries vote for us to get a position. So let me explain that. WHO, the director, is a voted position. The regional director for Eastern Mediterranean region, where I come from, North Africa and the Middle East, is voted by the ministers of health in this region. So if you have a country that comes to WHO and pays their dues and pays a lot of their dues, and WHO is putting a number that makes them look bad, they may have a reason to come and say, hey, let's talk about it, let's go back and forth and then negotiate this. Nobody voted for me to be in this position, and nobody voted for Chris Murray, and nobody voted for Marcia, and nobody voted for Farah. So we are here because what we do and based on our merits. So that gives us independence, and that's very important for an agency like ours to be independent. If you lose your independence, it's a big risk. That's one. Two, the independence comes with a price. You have to police yourself because now you're influencing numbers. And the way we do it is through this network of collaborators. And we have a Council for the Global Burden of Disease, which is our main product. That's a voting members. So if we decide to make a change on GBD and want to introduce it, there is a vote on that. Mm-hmm. It's democratically voted. There are some people from IHME on that because of the expert, but we vote like anybody else. And then we have this ICA run by Peter Piot that they tell us what to do and they go over the brilliant statistician review what we do. And then we have Lancet was their, because of the relationship with them and the fact they publish for us a whole issue, our reviews are more scrutinized, our manuscript, than anything else. And Lancet has a devoted set of people who review our articles. And some of them could be your fan, they love what you do, and some of them could be your competitors and your enemy. Remember, we're a university, we're competing for funds against everyone. So that keeps us on our toes and make sure that we are doing the best job we can do and providing the best product. The data quality, if you look at our visualization, and I don't know how many of you have seen the visualization that IHME has. So if you look at our visualization, one of our post-bachelor fellow, Kyle Foreman, I'll shout his name, early on when we used to produce a new run, we wanted to look at it to make sure the change from the previous one to this one, what happened. And we had to go through these tables, and then by expert, IHME is organized around topics. And then this expert will look, and then we'll send it to our collaborator on diabetes, say, look at the number in diabetes. They changed from 2.6 in this location to 2.7, let's say. Kyle came and said, no, I'll do a visualization for you that the colors change will show you how they change from one to another, from one run to another. So at GBD, when we finally production, there is like version 1, version 2, version 39, version 40, and between these versions, there are changes. And then when we looked at it, here we're sitting in, and this, is a young kid doing a post-bachelor fellow, my age, everybody is a kid. And I was like, man, that is a smart, brilliant idea. So now we're using this visualization not only for data quality, but also for people to use our data. And now we're going into automation. So we have a program, artificial intelligence, where if a certain change happen more than 5%, more than 10%, we put a trigger, and then we pull it and we look at it by eyes. And now in 2019, we're going to publish what we call waterfall. We have every year some new innovation. The waterfall is a mechanism to allow our data users to look at our data and the change from 2017 to 2019. How much of this change is due to more data coming to us? How much of the change is due to methodology has changed? How many of this change is due to aging, to growth, to change of risk factor? We want our user to know what the change from 1 year to 1 year, what is it coming from? And IHME, because of the collaboration, we get new data every year. When we published the 2000, I warned you, Lee, I'm very passionate. I could go on and on. You should stop me when you need me to. When we published the 2010 GBD, half of me is from Yemen. My father is originally from Yemen, and my mom is from Lebanon. The Minister of Health in Yemen, the GBD 2010, called complaining. He was a good friend, called complaining. Ali, what have you done? And you would expect Yemen, country with maternal and child health, diarrhea. That's his complaint. So you underestimated cancer in Yemen. How dare you? And you have to come here. And, Minister of Health calls you. We travel, and I do the Middle East. And I was like, Your Excellency, this is your data. He said, no, we have 2 data sources you're not using. Where are they? He has 2 cancer registries that we didn't have. He gave it to us. So providing data for a country and getting them involved, they want their data to look better. They want their data to be better, not look better. They want you to capture correctly what they have. And they were willing to share data with you. So right now at IHME, we have more data from, I hate to say that, but this is the truth. We have more data from China and Brazil and India than we have from the United States that we are aware of. So sources of data and what we have access to. We have more data from China, Brazil, Mexico. I mean, I could go on and on. So that's the collaboration. The more people collaborate with you, and now we are honored that we got some seed funding from NIH to a contract, not even a grant, a contract. They contracted IHME to do a burden of disease at the county level in the US by socioeconomic factor, race, ethnicity as well. And this is creating a new US collaborator group. NIH is heading, there'll be CDC, SAMHSA, and others. And we are looking forward to this because this will improve our quality of data for the US by us having access to more data from the US because of privacy and HIPAA and all this stuff. So we're having some problem with data from the US.
Well, you addressed my next question is kind of where is the work going? And even though GBD is the main product, you're extending it. You're making it easier for people to interpret change. I gather that the granularity is getting smaller. You mentioned that, at least in some cases, you have expenditure data.
Yes.
Is that true in the United States?
Oh, every country in the world. We have spending, health financing for every country in the world. In the US, we have more data and better data. So you asked me several questions. Let me address the finances first. The finances for every country in the world, and we have published in Lancet a projection of expenditure out of pocket, insurance, stock, where the spending is coming from. And we have a projection to 2050, how much spending will change in each country. And that's very important for us to know in every country in the world where we're heading in terms of health financing. So come back to the US. In the US, because we have much better data, we published, I'm not a co-author. When I say we, it's the royal we, I guess. And the second one, the 2050 projection, I'm a co-author. But we have a gentleman, a faculty called Joe Dillman, who heads our health finances. We published in the United States changes from 1996 to 2013 in spending. And we showed at that time that diabetes is now the number, 2013, was the number one most expensive disease and the fastest increase. And we showed what we called a decomposition in that manuscript, where we showed the rise in spending in the United States, how much of it was attributable to aging, growth of the population, change of risk factors. So some of the risk factors in the US, blood pressure is coming down in certain places, so costs will come down. And we looked in the United States also at inpatient, outpatient, and drugs, medication. And the fastest increase here in the US is cost of medication, where we don't do a good job as a country, like everybody else in the world, negotiating a price. Give the example for hepatitis C, Egypt and the United States, for example. So we can show where the spending is increased. And we see a trend in the United States where there is a shift from inpatient to outpatient. Mm-hmm. And what our hospitals have realized, they're not in the hotel business. You come in for a short time, we run all the tests that we need to run, we charge you for it, get out, somebody else comes next, where outpatient is becoming now more of a trend. We have a paper that we are working on now to update the spending. It should be in JAMA coming out soon. I can't tell you what the results, because JAMA doesn't like us to say that. But I can, if I make a mistake and slip off my tongue and say like diabetes is not the number one anymore, there's something else is leading the disease, I shouldn't do that. I'll apologize.
Yeah.
We're getting old, and then we're falling, and we're having back pain, we're having replacement here and there for stuff like that. So I can't tell you, though. Okay. Wait till you read our JAMA article, or attend one of our presentations. We present the data. IHME is, all what we do is public, and then we, with Lancet, if I tell you a number that we are publishing in 2019, Lancet doesn't mind that. They'll actually let us publish and talk about it before we publish it. JAMA is a little bit different. And we meet with the editors, and we abide by the rules. But we're an academic institution, and in order to get our product much better, we have to present it and defend it in conferences. So that we can present in a conference. And if you come to a conference that Joe or anybody from us has presented, you would have seen that back pain and neck are now costing us a lot of money.
My memory of that Dealman article is that it really helped understand this. I added to the understanding of the various factors that are driving cost increases in the U.S., and drugs is certainly one. But I remember pricing is, once again, as with other people's studies, a surprisingly big factor in the economics of it. But now, if you have all these data with this extraordinary granularity and time resolution, then a logical extrapolation is a model for possible interventions. So that if I said, I want to attempt a diabetes reduction or management program in my county, you could probably tell me what the consequences are most likely to be. Is that true?
Yes.
Do you have those models?
Yeah. So right now, what we provide, what we call future health scenario, the way we do it is, so for diabetes, for example, we take all the risk factors that are driving diabetes up and down, and when we do our projection to 2040, we take all these, say smoking is one of them, obesity is one of them. And we take every country in the world and we say, if you are 100 being the best performer on smoking, and if you go to 1% or 0%, you're the worst case. And we don't take the outliers. We take 85 and 15. So we're not taking the best performer. We take 85 and 15. So if you're 85 percentile on your performance of smoking, 85 percentile on diabetes, we do a projection, on obesity, we do a projection for diabetes. We give you a what-if scenario. In our grant was a contract with NIH, we want to do this for the U.S. counties. So now it's not global, it's U.S. county. Now, in our publication, that scenario is based on the globe, which means we're giving the U.S. an easier ride, yeah? Because we're holding, which is a country that spends more than anybody else on health. We spend $3.5 trillion on health, where the whole world spent $8. And we're not getting a return on our investment, so we spend money when we don't get return. Being rich, it's okay to spend more money on stuff. That's okay. But are you getting the return on your investment? And that's the debate in the U.S. We're not. So the future health scenarios will allow us. But you touch on a good point, and now it's okay if I talk about it a little bit. IHME board and IHME funders and IHME fans are coming to us and saying, you guys have done a wonderful job and you positioned yourself as the leader institution of telling me what's the problem is. That's good for you guys, but now you have to take it to the next level and tell me what's the solution. You have to be in that business. So we are now at IHME, we have a proposal that we would like to get funded, and we talked to Bill Gates in one of our presentations. And the idea here is data shows you as a country what's increasing the most in your country. So you could show in 2040 or 2050 what will be your highest burden, or you could come in 2040 and say what increased the fastest, not the highest now, what increased the fastest. So that's one bucket. The second bucket we want to do is we want to analyze all the intervention and policy for everything, and then failure and success. And failure is more important because we don't want to repeat the mistakes. We want to use our network of collaborators to gather all what people have done when it comes to an intervention, not only in health, trade agreement, legal agreement, tobacco and legal. So we want to look at a comprehensive way of doing it. And then we want to rank those interventions based on a star system, like what you do when you buy from Amazon or where you 5, 4, 3. We won't allow you a user. I want to use an intervention based on a 5-star system. Then the third bucket, we want to, if I apply this intervention, how much it will cost me now, and what's the return on investment in 2040, 2050? On burden of disease, on spending. We're going to spend more money, but we're going to spend less money, hopefully, than what we are. And then we're adding one component saying, if somebody is a user, I have $5 million, and where should I spend that money? And we have a grant. We did a grant. When I say we have a grant, Marcia, who's sitting here, did all the hard work and a visualization on this one to show an intervention, what will happen. And this was funded by the Bill and Melinda Gates Foundation. And now we want to scale it up for every intervention. So the debate here is when IHME does this, and it's a big project, as big as GBD, and as big as our core funding right now for, who is going to use it? So people ask you, who's going to use it? So here is my theory, why we are at IHME and why our people who love us and people who want us to do more are coming and pushing us. So right now in many countries in the world, investment in health, whether we like it or not, and I'll give you an example in the United States. When I was at CDC, senator called Paul Coverdale died from a stroke, then CDC got money for a stroke registry. I mean, it wasn't like stroke is a big problem in the US, we should fund you to do something about it. It was when a senator died from it. And so in many countries in the world, even in our country here in the United States, funding sometimes is at the whim of the guy, the president, his wife, has breast cancer, let's spend money on breast cancer. If you do it right, now the spending is on what's the biggest burden, because the first bucket tells you what's the problem. So it's very hard when you make this public information, what IHME is intending, for somebody in Lebanon right now, if you're following the news in Lebanon, we have kids demonstrating in the street and older people, they want change. Nobody in Lebanon can come and say, I want to spend money on this topic, because now we told them what the burden is. That's one. Even if the policymaker in Lebanon doesn't pick the first, the second, the third, picks the fifth one, the intervention right now, they cannot spend money anywhere, because we have a solution for it that is STAR system. And the media will come after him and her, say, why are you doing this for breast cancer, where IHME data shows it doesn't work? So that's very important for us, empowering policymakers with the right data, empowering people who want to do the job correctly with the information that they push for the right change and ask for investment in the right place at the right time to solve the problems based on what we see. And the beauty of what we are proposing is the solution is local, because GBD is local. So a solution for breast cancer in Lebanon is going to be different than a solution for a breast cancer problem in Nigeria, in the US, in Alabama, in Seattle, in Atlanta. And we cannot solve the problems as one solution fits all. We have to allow that flexibility and let the data dictate, giving my socioeconomic factor, giving my income, giving my fertility, giving my education, what works for me here, giving my other risk factor, what works for me in my area. Please keep an eye on IHME. This is something that we should get funding to it. We have some smart people helping us to get the money, and at the term of some of our friends shaking the tree for us. And then soon, inshallah, as we say in Arabic, we'll get funding for this, and we will move from not only providing you with what's your burden, is also, in addition to telling you this is a problem, providing you with a solution that's uniquely good for you.
This is very powerful stuff. The data alone are enough to shame me into acknowledging my failures or the failures of my jurisdiction. But if you then offer prioritized solutions, and then you offer me a positive way forward, something to point to that's other than my political considerations. So the potential for this to really have an impact is huge. This is very, now before we come back to some of the ways forward, let's give us a little summary on the population health initiative, and
thank you.
What is it and why is it here?
Thank you. So can I talk about the shaming a little bit? I don't want you to. Yeah. Shaming is good. Shaming is in many ways works. So shaming, I'm not here to shame people for the shame. I mean, that's not my business. I'm not political, I'm not religious. We're not in that business. Shaming works in different ways. So one is you know your number compared to people like you. And at IHME, we do something called observed over expected. So what you're expected to perform, giving your deck of cards, and then what you are performing. So observed, in the United States, observed life expectancy, over expected life expectancy, and that's shaming. You're not doing very well. Then the other thing, the shaming is when you do it at the lower level. Because if I go to a minister of health, I can use countries as an example, and I apologize. So some of the stuff I will say are not IHME view, are not University of Washington PHI views. So let's take a country and say, I'm talking about this country, let's say Lebanon to be safe. So if you present a data for Lebanon today, and you do it by local level, which we do local burden of disease, and the Minister of Health or the Prime Minister in Lebanon is telling you, I cannot do it, Ali, this is too much work. Then you say, but Your Excellency, you've done it here. Why haven't you done it here? That's the shaming we're after. We're shaming after in a county in the United States to tell the policymaker, you're able to do it here. Why can't you do it here? One. Also, the shaming shows a county or in Lebanon, let's call in Lebanon, counties in Lebanon that are performing better than they're expected given their demographic and their income. And then this questions start, why, what's happening? That shared knowledge is very important. So shaming is very important, and putting the US in terms of global where we stand is very important, and I'd like to do that. Now, you can't shame people for the shaming. So when I was at CDC, I used to publish about behavioral risk factors, and I used to publish a lot about obesity, mammogram, all the stuff. And Mississippi at that time either was like 50 or 49 every time. And finally, at that time there was a powerful senator and congressman from Mississippi, and they sent a nasty letter. Sorry, the word nasty is very conservative here. To CDC director at that time, who was a very close friend of mine, saying, enough is enough, man. You tell us every year we're bad with the last. Okay, what is CDC doing about it? And then that started the translation and implementation work with these. So the shaming, I cannot shame you and blame you for something without me being in your shoes and giving your deck of cards, can I do it better? And that's very important. So IHME is at that level of work. I cannot go to a county in Lebanon and say, you should be better, but knowing what they are and what they're dealing with. And the most important, without providing a way forward. Without coming to them and say, so what? What can you do about it? And which one of these issues that you are facing with are easier to intervene on and easier to fix? Until you reach the promised land of eliminating poverty and education, but we have work to do right now. Address your risk factors, your smoking, address your blood pressure, and let's work with you on some programs to do that. And as I mentioned, we have people at IHME that do policy report, and we do training of policy as well, and how to take our data and build a policy on it. So that's why we are excited as leadership at IHME, even our staff. Our staff who work day and night on our product, and they, slowly, it took us a long time for them, because they're working here in Seattle, they don't travel and see the power of our data in global countries. So like I just came from Pakistan, we had 4 of us, 3 from our IHME, one physician at IHME who runs our medical record. And by the way, we're using medical record right now in our GBD. We have over 7 billion medical record at IHME right now, and we're getting. Wow. So and then we have a data analyst, and we have a project officer. And they get to, the Minister of Health came to talk in our training for GBD, and why GBD is important, why he wants to work with IHME, why it's important for his policy in Pakistan. Then we met with him in his office, and our staff got to see it. What I work here day and night is making a difference on the ground. The same people who are motivated to produce the numbers are now coming to us and say, oh yes, we want you to be in the solution business. Yes, we want to be part of the solution. And then if you imagine IHME for the numbers, we have 4,300 collaborators. For geeks and numbers. So I'm a geek. Let's call ourselves by name. So number geeks. Imagine, Lee, how many collaborators we will have when we open the door for translation and implementation.
Yeah. Very powerful. Very powerful. Okay, so a brief synopsis of
Population Health Initiative.
Population Health.
A word from our sponsor. So let me show my colors here. So Population Health Initiative. I'm hopeful I'm not. The president of the university, Anna Marie Kausi, University of Washington, came to us and said, I want to energize my university, and we're an institution, premier institution in education, but we can do better. Everybody in the world deserves to live longer and healthier, and we should do something about it. And we as a university are best positioned to do it. We have 9,000, almost 10,000 between faculty and staff. We have wonderful students, and we should be doing better when it comes to population health. So we started this initiative, 25 years initiative, got a vote of confidence from Bill and Melinda Gates Foundation for $210 million for a building. You'll see a nice building coming up. We just announced it will be named Hans Rosalind Center for Population Health. Will house IHME, all in entirety, part of School of Public Health, part of the Department of Global Health, and of course the Population Health. And it's a place for us to meet. The idea on Population Health Initiative is the problems that you and I have been talking about today cannot be solved by one group. It has to have a multi-sectorial involvement. So everybody at the university, engineering, law, arts and sciences have to be involved. And yes, from a leadership position at the university, being a UW, I still want my engineer to be the best engineer in the world and my physician to be the best physician in the world. But I want them to know that they have a bigger role to play. And I want them to know that there are other things that are important, and they know about art and engineering. And we decided at the university, how could we recruit the best students? Our students are coming to us right now, and they want to do more. They don't want to learn only one topic. They want to do a lot of things. They want to change the world. And we have brilliant students coming to us. And how we can recruit the best faculty and engage them. A faculty right now doesn't want to come and work on a tiny little problem. They want to work on solving major issues. The easy ones, let somebody else do it. Let another university deal with it. We want to big the challenges. So we put together a council and then we came up with 3 areas to focus on. We have funding from the university to hire best faculty. And let me be a little bit specific here. I'm passionate about Population Health Initiative. One of our schools, which is one of our, when you talk about population health, you need to invest in that school, and you need to make sure that school is doing extremely well. Part of their promotion for their faculty, one of the requirements is how many single author publication. Here, talk about collaboration. And then you have to publish a paper by yourself. I'm not going to say it's a school of nursing, but it's a very important school. And then when we went and talked to them, the dean of nursing, who's one of our most, she's a fire, said, no, I'll change it. I'm willing to even joint hire, and I'll free some of my faculty to do bigger picture on population health. Then at UW, we realized we cannot do it alone. We need to partner with a lot of people. As great as we are, partnership is important. Then we realized we'll be a bunch of hypocrites if we don't do it within our own campus, within our own city. So we're working with King County, within our own state. Before I go to Mississippi, I need to show that I can fix my problems within. So we've done a lot of great things at the university, from homelessness for our students, and we do have students that are homeless. From feeding our students, we did a survey. You've seen it in Seattle Times. We funded that part of that survey from PHI, Population Health Initiative, to show that some of our students are struggling with rent. They cannot afford to eat. We started a food bank on the university where students can get free food. And then we decided also, in addition to collaboration and paying attention to internally, if we set out to say we want to do everything on the face of the world, we will be a mile long and an inch deep. We can't afford that. We have to be about substance. So we're focusing on grand challenges. And then we also, the university, wanted to show that it's not an idea and we want to go and get money for it. We at the university, at a hard time what our university is facing, and you know that more than I do, financial challenges. We said that we need to invest in this population health initiative, where we gave what we call grand challenges around these priority areas. We gave $50,000 to a faculty from ours, and one condition. One, then more faculty, different school working together. Can't be one school. You have to work together. Then the provost gave us money for hiring junior faculty towards retirement, $150,000 per year for 4 years towards retirement, on one condition. It has to be a joint hire. And for those of you who don't know UW, doing a joint hire is a pain as hard as it is. But the university is doing that. And then the university right now is at a stage where we're open for business. We're partnering with a lot of other universities who are wanting to do our model. We have some companies that I cannot name coming to us. They want our services. We planted that flag that now you could come to me as a company and say, I want to improve the health of my employee or my farmers. And for the first time in the history of UW, you could come to one place and we could arrange all the meetings that you want to. Navigate a ways within our university. If you're interested in early education, in college education, in medical care, in legal, how could you navigate UW without knowing people? But you come to us in the Population Health Initiative, which is in the President's office, and then we've had meetings that somebody could come, and we arranged 23 meetings from like 18 different departments. And then we could give you the menu of UW for collaboration and what we can work for you. PHI is now moving to PHI 2.0. We're in tech area where we felt we get our act together as a university. We have the buy-in. Our mandate, when I started doing this for the university, at that time, the provost came to me and the president and told me, Ali, this has to be from the bottom up. You have to do your job. This is not Anna Marie Kause announcing, I want a population health initiative and let's go and do it. It doesn't work this way. You go and meet with everybody. So the first 2 years I spent, the university, meeting with dean, chairs, faculty, asking them what works for you and then how. And one of our, I'm a metric person. We put metrics, what we want to do, and our success story. One of my favorite metrics for Population Health Initiative that we're succeeding within the university is how many emails I get people yelling at me or calling my boss, in this case, the president, saying, why I am not on the council of this Population Health Initiative. Why I'm not? I get this email. My favorite email, like one of a faculty that I know, I'm from the Department of Biostatistics. We're the #1 in the world. Why aren't we sitting on the council? So when you have faculty offering their free time and they're busy to come and work with you, that's a sign you're doing something good. We have energized our university and our students, and we have built an infrastructure that we want to change the world, and then we have smart people and smart staff working on some of the biggest challenges we are facing. Global to local is very important for us. And then, to my surprise, from a university, as big as we are, and we have silos or whatever people call them, center of excellence, that, it happened to me. I went to Jordan working on Syrian refugee. At CDC, I was trained to do emergency and refugee health. I met one faculty who's working on Syrian refugee. I've never known who she is and what she is. And she's doing a project that I could have helped her, and my project she could have helped me. So here is UW. You meet somebody from University of Washington in a conference. So we're doing what we call dating. What is it? The rapid dating? Speed dating. I don't use speed dating. I have a daughter who's 19 years old, so no dating. I wish. But speed dating, Farah knows my daughter. So speed dating, and then one of our person who is working on a emergency and refugee health met a faculty who was working on water quality. And he said, for the past 5 years, I've been looking at an expert, and you're here in front of me. PHI is serving also as incubator for new ideas. So we want new ideas that come that we want to do. We'll put it at the central with the president office. We'll make sure it grows. Then it goes back to where it belongs in the university.
So the summary here is that IHME has evolved an astounding data system of great depth, and it's continuing to move that forward. And now the university is surrounding it with a collaborative structure that is going to enable people to find each other, take advantage of the data in new ways. Is the speed dating open to people from outside the university?
Yeah. Yes.
That's the key.
Yes.
See, in this audience, you will find people who are providers trying to do healthcare better, policy people, technology entrepreneurs who are trying to understand what does IHME's data tell us about directions and opportunities, and if there's a way that they can take this new awareness and connect with you, the impact could be terrific. So I think this is very revealing
PHI is, I wear two hats, so I want to say it clearly. PHI is not about IHME. There are many great things that are happening at UW. But here I was invited to talk about IHME. If you brought me to talk about PHI and different things, I could talk about protein and how we're changing protein and in order to solve diseases at UW. There are great things going on at UW. PHI is very comprehensive, that's one. But I will say it differently, Lee, and you know UW, you've been at UW for longer than I am. IHME has showed what the burden is. The University of Washington cannot afford that somebody else, another university, God forbids, another university, takes what we have and run with it when it comes to translation and implementation and solution. We can't afford that. We will fail as a university. So the Population Health Initiative is a great way for us to come and say, IHME is doing something good, and engineering and law, we're doing some great things here and there. How could we make sure that all the data that we're putting out is put to a good use? And why we called it Population Health Initiative? Because if I go to a prime minister in a country or a president in a country, the best entrance to them is health. People get sick, especially these leaders are getting older, my age and older, and they pay attention to health more than anything else. And we are an educational institution. You have education and health. These are the most important things for economical development. So we feel strongly that with the capacity that we have and the support in our community, and everybody is welcome, we're a tech area. We can find innovative solution. Like we came right now, one of our incubation is emergency and refugee health. And we have a certificate on it, and we want to move it, and we got funded.
Wow. Okay.
And then we come late. UW is coming late to this game of emergency and refugee health, where you have like Hopkins and Columbia that have been programmed. There is a degree coming out from them on that. But when we came and we looked at it from a population health initiative, and everybody at UW saying, how could you compete with these guys that are out there? Technology. We're an innovational hub here that we could come up with an app faster than anybody else in this country. Seattle will support us to do that. We have the global experience. There are people here who, I look at you, what you do in Washington Global Health Alliance. We can bring people on the table from different groups. And then we could do a lot of things here that nobody else can do. So we should bank on our strengths. But we, as a community, I would really, if I will end up on, don't let any other university take our success and build upon it for solving the health problem. If they beat us and they do it, good for them. But I will hate it if somebody else do it. We want to improve the health of the wood, and we want to be the one who's doing it. So if you know somebody who has $300 million to give, please send them my way. I have a great idea for them and the best $300 million they'll ever spend.
Well, the corollary is it's opportunity for all of us to
very important.
take advantage of this remarkable strength that's right here in our community. So let's open it up for questions. Please wait for the microphone because we are recording this.
Hello. Earlier on, you mentioned that we don't have enough data compared to, say, China or India. Could it be because of our HIPAA restrictions? I'm curious.
I mean, today, very good question. So today, I've been in a meeting before here, and I feel like the questions are very good, very smart questions, but they're going to get me into a lot of trouble. I answer honestly. And people who know me at IHME, at the university, there's so many things going in my head, so I can't lie. I have to tell you exactly what, because I won't remember what I said. So I have to stick to the truth. Not, I want to be politically correct, but I can't because I have to remember. Yes, there are some of the things that are happening here that are being prevented by privacy. But I have to say at the same time that unfortunately the history of the United States, we've made mistakes in privacy and we abuse people. But we want the other extreme, and we need to come back around. So let me be very specific here. I have on my cell phone all my contacts, all my banking, a lot of things here. I don't have my medical record here. I own my medical record. Why can't I have my own medical record? And if I want to give it to you, it's my right to give it to you. We are not at this stage in the United States. That's one. Two, if you go, let's talk about Lebanon so I'm safe. If I go to my village right now in Lebanon, take out sexually transmitted diseases, everybody who has a disease will come and talk to you about it and show you the medication they are on, because everybody knows everything. So there is, privacy, and the government in Lebanon will not stop hiring you if you are diabetic or you have a condition. So here, the privacy, people are afraid because maybe they will not be hired or their insurance will go up. But unfortunately, and here where I get in trouble, it's a misguided conception that my privacy is protected. There's no privacy. I'm very optimistic that in the United States it will change because of the new generation. I mentioned I have a 19-year-old daughter. She says stuff on her, whatever, that I would never dreamed of. The new generation is more open about it. But the HIPAA and this regulation became to a point that people are using them not to share data. And bureaucrats sometimes don't like to share data. We see it in many countries. So, because it makes them look bad, and they don't want to look bad. They don't want to be accountable. They hide behind that. That's fine from the bureaucrat standpoint, but it reached a point in the United States that it's hurting some of the people themselves. So you have an older woman coming to a doctor and saying, have an emergency. All what she can tell you, I have a heart condition, I take a white pill in the morning. Go figure. So if it's impeding with our ability to provide services at the community, we should revisit it with safeguards, making sure that privacy and it's not being abused. But if you Google Ali Mokdad and you put 411 and Google Ali Mokdad, for $90 you could get my criminal record. I don't have any, but you could get who lived with me, and for some people you could know history of dating from people who lived with them. There's no privacy anymore. People call you and tell you, give me your last 4 digits I want to verify your last 4 digits of your social security. That's your social security. People don't know in the US, your last 4 digits, that's your social security. And then you hear it happening all the time. And then in the US, what we have done wrong is we linked a number, unique number for us to our finances. So in Lebanon, if you have a ID, national ID, which is your social security, it's not your bank account. So people give it to you. Yeah, okay, link my medical record, take it, because you can't steal my money. Here, if I give you my social security, you can get my bank account. Yes, HIPAA rules are prohibiting from doing research and prohibiting us from doing a lot of things, but still they're needed, but they have to be revised. But let me tell you about the data. Let me give you about the data. You started. In the United States, we don't know at the county level what people are dying from sometimes, from certain diseases at certain locality. And they died. We can't because of privacy issues. In the United States, we don't know what people eat at the state level. We don't have an estimate of diet at the county level. We don't. We use, from IHME, we use sales data, we use restaurants data, we use FAO data. Lots of data are missing. And here is diet, which is one of the most leading risk factors for diseases in the United States. And we talk about diet, and we don't have a handle of the diet of our population. We don't know in Washington state how many people are diagnosed with diabetes, how many are treated for diabetes, how many have the diabetes uncontrolled. We have NHANES survey, which is national. They do 15 PSUs. They don't tell you what PSU, where they were. Privacy. And we don't know. And here, diabetes, I was meeting with people from the state. If you know you're a pre-diabetic, you're more likely to change your behavior. We don't know that. We cannot put a message in King County, in Clallam County, in any county, say, based on your diet, this is what you need to do. We don't have good handle on that. So yes, we are driving blind in many places in the United States because of that. And then when you don't have the data, you don't have the evaluation. Because if the data is murky, who's held accountable for doing a good job? Because we don't know. And then if we don't sit down together and agree on data system and then have a good data output, people who are against us, who doubt our results, will say, you guys don't know what you're talking about in the health system. If one survey is saying a number, another survey is saying a number. So there is a big problem here than HIPAA. It's impeding us from intervening. It's making us look bad. It's not allowing us to do our job.
Well, he warned us that he's passionate about.
And I talk a lot, so.
He talks a lot.
And I'm going to be here as long as you want me to.
But I'm going to suggest that we bring this part of it to a close, invite everybody to share some refreshments, and
I'm here.
corner him and his colleagues.
Yeah, I have a lot.
We can't let them get out of this conversation.